Welcome back to the Deep Dive, where we really try to extract the most vital insights from a stack of sources, turning complex topics into clear understanding. Today we're diving headfirst into the very first, and you could argue, the most critical step of modern laparoscopic surgery. You know those incredible keyhole surgeries you hear about, minimal incisions, tiny cameras, almost unbelievable precision? They've really revolutionized medicine, haven't they? Patients recover faster, less pain. It's amazing stuff. But have you ever stopped to wonder truly what makes these delicate procedures even possible? It's not just the fancy cameras and instruments you see later on. It's the fundamental, high-stakes initial entry into the patient's body. It's kind of the moment of truth that unlocks everything else.
It's absolutely true. I mean, the public, understandably, they're often captivated by the high-tech visualization, the surgeon's dexterity once inside. But for us in the surgical community, you hear this at every conference, that initial access, that first breach of the abdominal wall, it's really the unseen foundation. It's the gateway, you know? And if that gateway isn't established with absolute precision and safety, the entire procedure, no matter how skillfully executed later, can be compromised. It's where the whole success story either begins or, unfortunately, sometimes ends before it really starts.
And that's precisely our mission today. We're going to explore the foundational tools and techniques that allow surgeons to achieve safe access in laparoscopic surgery. We'll be drawing from, well, a fascinating array of articles, research papers, clinical insights, basically trying to give you a really comprehensive understanding of these unsung heroes, the access instruments that make minimally invasive surgery a reality. We're going deep into the engineering, the decision-making, the constant drive for innovation that surrounds this seemingly simple yet incredibly complex first step.
What's truly fascinating here, and again, this comes up in expert discussions all the time, is how this initial sort of blind spot in surgery, literally the first millimeter of entry, drives an entire industry of innovation. It's constantly pushing against that inherent tension between surgical efficiency and absolute uncompromising patient safety. Without a safe and effective way to simply enter the abdominal cavity, the advanced surgical work, it just can't even begin. It's the critical precursor, and understanding it is key to appreciating the entire intricate dance of modern surgery.
Right, and the stakes, as you alluded to, they just couldn't be higher. We're talking about patient safety, obviously, but also the ripple effect on the entire healthcare system, the trust patients place in these procedures, and, the continued evolution of surgical practice itself. The choices surgeons make about methods and instruments for that initial entry aren't just routine clinical decisions, they're high-consequence calculations based on years of experience, anatomical knowledge, and a constant need to stay updated on the latest evidence, the kind of stuff that fills lecture halls at surgical meetings.
Exactly, but this isn't merely about getting in, it's fundamentally about how you get in, making absolutely sure no harm is done to vital structures underneath. When we discuss this at medical conferences, those first few minutes of any laparoscopic case, they're always highlighted as a peak risk period. Seriously. It sets the stage for everything that follows, and any misstep here, any miscalculation, can cascade into severe complications. We're talking about affecting patient morbidity, mortality, the overall outcome. It's truly the critical first domino in a very intricate and delicate sequence.
Okay, so let's peel back those layers then and start with that critical first step. When surgeons talk about access in laparoscopy, what precisely are they referring to? What does that actually entail for the patient lying there?
Right. So at its core, access in laparoscopy means creating a safe, controlled entry point into the patient's abdominal cavity. It's definitely not just punching a hole. It's a meticulously managed process. It's designed to minimize trauma to surrounding tissues and organs, and it establishes a secure, sealed pathway for all the subsequent surgical maneuvers. Think of it like constructing a temporary airtight tunnel through the abdominal wall, a tunnel that allows you to work precisely without disturbing the external environment. This tunnel, it needs to be both stable and innocuous, if that makes sense.
You use the term meticulously managed. That implies there's a lot that can go wrong. And here's where it gets, well, really interesting, because the potential dangers of this initial entry are severe, aren't they? Injury to major vessels, the bowel, solid organs. These can occur if entry isn't executed with extreme care. The phrase blind entry often comes up in this context. Can you truly unpack why it's referred to as blind and what specific dangers that implies?
That's an excellent question, and it's really where the tension in laparoscopic access truly lies. Many of these initial entries are indeed blind to some extent. What we mean by blind is that the surgeon isn't directly visualizing the very tip of their instrument, whether it's a needle or a trocar, as it penetrates the various layers of the abdominal wall into the peritoneal cavity. They're relying on, well, anatomical landmarks, tactile feedback, what they can feel, and sometimes even the subtle sounds of tissue layers being traversed. And the dangers, they're profound. An inadvertent puncture of a major retroperitoneal blood vessel, like the aorta or the vena cava, that can lead to immediate, massive hemorrhage. We're talking emergency open conversion, blood transfusions, and it can potentially be life-threatening. I remember hearing a senior surgeon once say, the most dangerous 5 minutes of a laparoscopic case are often the first 5, and it sticks with you. Similarly, an injury to the bowel that can cause spillage of intestinal contents, leading to peritonitis, severe infection, a prolonged, complicated recovery, sometimes needing multiple follow-up surgeries. Injuries to solid organs like the liver or spleen can also cause significant bleeding. These are not minor incidents, they are major surgical catastrophes. And that's precisely why safety protocols and the choice of the right technique are just paramount.
Wow. It sounds like a high-wire act right from the absolute start. So, how do surgeons manage this inherent risk? Our discussions, and certainly the material we've reviewed, talk about the 2 pillars of access. Let's break those down, starting with the first one. Creation of pneumoperitoneum. For those of us who aren't in the operating room, what does that mean beyond just, lifting the abdominal wall?
Well, let's maybe retire the inflating a balloon analogy first. While it's simple, it really undersells the physiological sophistication involved. Pneumoperitoneum is the controlled insufflation, that's the blowing in of carbon dioxide gas into the peritoneal cavity to distend the abdomen. This distension creates that crucial working space, pushing the abdominal wall away from the underlying organs. It gives you room to see and room to move. But it's a precisely controlled environment, more like a carefully managed pressurized chamber than just a balloon.
And why carbon dioxide? We've touched on this briefly, but for a deep dive audience, what are the specific considerations that make CO2 the gas of choice? Why not just air?
That's a critical question. CO2 isn't just picked arbitrarily, it's very carefully selected for several compelling reasons. Firstly, its rapid absorption. If any CO2 accidentally gets into the bloodstream, it's quickly dissolved and then expelled through the lungs by breathing. This means that if there's an accidental gas embolism, which is a rare but serious complication, it's generally far less dangerous than an air embolism, which could be catastrophic because nitrogen isn't easily absorbed. Secondly, CO2 is non-flammable. This is absolutely essential in an operating room environment where you have electrocautery, lasers, other heat-generating instruments being used all the time. Imagine the disaster if a flammable gas were in use. Thirdly, it's readily available and relatively cost-effective. But beyond these basic properties, the physiological impact of pneumoperitoneum is actually quite complex, and it's constantly monitored by the anesthesia team. The increased intra-abdominal pressure can affect the patient's cardiovascular system, potentially reducing venous return to the heart and increasing systemic vascular resistance, basically making the heart work harder. It can also impact respiratory function by elevating the diaphragm, which reduces lung volume. This can make ventilation more challenging for the anesthesiologist, especially in patients with pre-existing lung conditions, like COPD or asthma. Modern insufflators, the machines that deliver the gas, are highly sophisticated devices. They're constantly measuring flow and pressure and often communicating directly with the anesthesia monitors to maintain this delicate balance. It's a continuous, dynamic interplay between the surgical field and the patient's physiology.
That makes perfect sense. You need not just room to work, but a stable and physiologically compatible room. And that brings us neatly to the second pillar, placement of trocars and cannulas. You mentioned earlier these are the conduits, the doorways. Can you tell us more about their combined role and maybe the sophisticated engineering behind them?
Absolutely. The trocar and cannula are intrinsically linked, like a drill and the hole it creates that you then line with a pipe, maybe. The trocar is the obturator, the component that actually creates the initial opening or pathway through the abdominal wall. It can be sharp, blunt, or optically guided, as we'll discuss. Once that pathway is established, the trocar is removed, and what remains is the cannula, the hollow tube that stays in place. These are the actual portals through which every single laparoscopic instrument, from the camera to the graspers, scissors, staplers, everything, is introduced. And these aren't just simple plastic tubes, not at all. They are precision-engineered devices. The cannula acts as a stable, sterile sleeve. It protects the incision from repeated instrument passage, it prevents gas leakage to maintain that vital pneumoperitoneum, and it provides a smooth, low-friction pathway for instruments. Think of them as the high-tech doorways into your surgical workspace. They're designed to withstand hours instrument manipulation, gas pressure, and maintain sterility. Their role is fundamental to both surgical efficacy, getting the job done well, and preventing post-operative complications at the port site, like infections or hernias.
Okay, so once that crucial working space is created and those precise doorways, the cannulas are in place, how do surgeons actually get those trocars and cannulas in there safely in the first place? Our sources detail different techniques for entry. It seems there's no single best way, but rather a strategic choice based on the situation.
Precisely. There are broadly two primary time-tested techniques: the closed and the open approach. And alongside these, there are some newer evolving methods that kind of combine elements of both. The selection of technique is a significant decision. It's often influenced by a surgeon's training and preference, absolutely, but crucially, by the patient's specific medical history, any prior abdominal surgeries they've had, and the specific clinical scenario you're facing. Each technique carries its own risk-benefit profile, and surgeons have to weigh these carefully for every individual patient. This is a topic of perennial discussion and research. You see it presented at every major surgical conference. People are always debating the nuances.
Let's start with the closed technique then. This is often associated with the Veress needle approach we touched on. This sounds a bit like what you mentioned earlier about a blind insertion, correct?
That's right. The Veress needle approach is the classic closed technique, and historically, it's probably been the most widely used. It involves inserting a fine spring-loaded needle, that's the Veress needle, through the abdominal wall into the peritoneal cavity. This needle is used to initially insufflate the CO2 gas, creating the pneumoperitoneum, that working space. Once sufficient working space is established, maybe a certain pressure is reached, a larger trocar is then inserted, often at a different site, usually aiming for that pre-created gas cushion. The primary appeal of this method has always been its speed and efficiency. It's generally quicker to establish access compared to the open technique. However, its blind nature, both for the initial needle insertion and often for the subsequent primary trocar insertion, means the surgeon relies very heavily on tactile feedback, feeling the layers pop, and those specific confirmation tests we'll talk more about. It makes proper technique and vigilance absolutely critical. It's a moment of immense trust between the surgeon and the instrument and their own feel.
Okay, so a trade-off. Speed versus the inherent risk of that blind insertion. That brings us to the open technique, also known as the Hasson advantage, or just the Hasson technique. How does this fundamentally differ, and what problem was it designed to solve?
Right. The Hasson technique, or open technique, fundamentally addresses that blind aspect that we've emphasized as a concern. Here, the surgeon makes a small incision, typically less than a centimeter, sometimes a bit more, and then meticulously dissects down through the layers of the abdominal wall skin, fat, fascia, muscle, peritoneum under direct vision. They see exactly what they're cutting. Once the peritoneal cavity is reached and confirmed visually, a specialized Hasson trocar, which has a blunt tip and usually a cone-shaped sleeve, is then inserted directly into this opening. The crucial differentiator is under vision. This significantly reduces the risk of initial injury to underlying structures like major vessels or bowel, because the surgeon can visually confirm each layer, identify any adhesions, or avoid vital structures. It's often considered a crucial safety mechanism for specific patient populations, particularly those with a history of prior abdominal surgery, where adhesion scar tissue can make blind entry incredibly dangerous. The initial approach might take a few minutes longer, maybe 5 minutes more, but that time is really invested in significantly enhanced safety.
So on one hand, the closed technique offers efficiency but relies on blind entry. On the other, the open technique is slower, but it's under direct vision, dramatically reducing that initial risk. It really sounds like safety is a constant driver for surgical innovation here. And our sources point to evolving methods like optical and direct trocar entry. What are these new kids on the block, so to speak, and what problems are they trying to solve or improve upon?
These newer techniques truly represent that ongoing quest for even greater safety and efficiency, often trying to combine the best aspects of the traditional approaches while mitigating their drawbacks. Optical trocars, for example, are a significant advancement. They actually have a built-in scope, like a miniature camera lens, right at the tip. This allows the surgeon to visualize the tissue layers as the trocar is advanced. You can see in real time on a monitor the fascia, the muscle, the fat, and then that glistening peritoneum as you breach it. It essentially combines the direct visualization benefit you get with the open technique, but with a more streamlined, less dissecting insertion process. It offers real-time feedback and largely eliminates that blind element that traditionally concerned us with closed techniques. Then there's direct trocar entry. This method, it often involves inserting a bladeless trocar directly into the abdomen without prior Veress needle insufflation. It relies on meticulous technique, precise anatomical knowledge, and very careful control to penetrate the abdominal wall. The idea here is to reduce the number of steps you avoid the Veress needle step entirely, and therefore the potential for 2 separate injury events, one by the Veress, one by the trocar. It often utilizes a bladeless system to minimize tissue trauma during that direct insertion. It's a technique that has been rigorously debated and studied. You see comparison trials presented at conferences. Its proponents highlight its efficiency, while proponents of the Veress method emphasize the layered safety checks of initial insufflation. These methods are frequently the subject of lively panel discussions, with surgeons sharing their clinical experiences and data to refine best practices. The goal, always, is how can we make an already safe procedure even safer, especially in varied patient scenarios, constantly pushing the boundaries.
It's just incredible how much the thought and engineering goes into literally just getting inside. Now let's talk about the arsenal of access, the sophisticated instruments themselves that make these techniques a reality. First up, the ingenious Veress needle. You've hinted at its cleverness. Can you delve into its design and function for us? It sounds simple but effective.
Absolutely. The Veress needle is, well, it's a marvel of simple yet incredibly effective engineering, often underestimated in its brilliance, I think. It's a spring-loaded, hollow needle, typically about 12 to 15 centimeters long, maybe a bit longer for obese patients. But its genius lies in its dual-lumen design. It has an outer, sharp cannula designed to penetrate the abdominal wall layers, and crucially, a blunt inner stylet. This inner stylet is spring-loaded, and it's retracted when the needle is pushed against resistance. So as the sharp outer cannula passes through successive layers of tissue, skin, fat, fascia, muscle, it encounters resistance, right? However, the instant the tip breaches the final layer, the peritoneum, and enters the free space of the peritoneal cavity, that resistance abruptly drops. At that precise microsecond, the blunt inner stylet, propelled by its spring, pops forward, extending just beyond the sharp tip. This action immediately transforms the sharp penetrating tip into a protective, blunt end. This elegant engineering prevents, or aims to prevent, the sharp tip from inadvertently injuring underlying organs or vessels once it's popped through into the free space of the abdomen. It's a brilliant example of a mechanical safety feature built into a critical instrument. Its primary role, of course, is to then allow insufflation of CO2 gas and create that initial pneumoperitoneum we discussed.
That's a truly ingenious built-in safety mechanism, like a little shield popping out. But because it's still an insertion without direct visualization, relying on a tactile pop, our sources highlight critical confirmation tests. These aren't just good practice, are they? They sound absolutely vital. What are these tests, and why are they so non-negotiable?
Oh, you're absolutely right. These confirmation tests are not merely good practice. They are vital, non-negotiable safety checks. Precisely because of the initial blind nature of the Veress needle insertion, they provide crucial objective verification that the needle is correctly positioned within the peritoneal cavity and not, for example, stuck in an organ inside a blood vessel or just sitting within a muscle layer or the preperitoneal fat. Skipping these tests or doing them improperly is frankly an open invitation to catastrophe. There are 3 key sequential tests that are typically taught and performed. First, the saline drop test. After inserting the Veress needle and hopefully confirming the tactile 2 pops as it passes through the fascia and peritoneum, you attach a syringe with maybe a few milliliters of sterile saline to the hub of the needle. Then you place a few drops of saline onto the hub, just letting gravity pull it down. While the drops are sitting there, the surgeon or an assistant gently lifts the patient's abdominal wall. If the needle is correctly placed in the free peritoneal cavity, the slight negative pressure that's created inside the abdomen by lifting the wall will actually cause the saline to be drawn or aspirated into the cavity. You see it disappear. If the saline just sits there, or if it runs down the outside of the needle, that's a strong red flag. It suggests the needle isn't in the free peritoneal space, maybe it's in a different tissue layer, or even pressed up against an organ. It's a simple yet powerful physics check.
Okay, that makes sense. Negative pressure pulls it in. What's next?
Second, the aspiration test. Immediately after the saline drop test, with the syringe still attached, the surgeon attempts to aspirate, to pull back on the plunger. The goal here is to confirm that no blood, no bowel contents like air or fecal matter, no urine or any other bodily fluid can be easily aspirated back into the syringe. If any of these are aspirated, even a tiny amount, it's a clear, unequivocal indication of misplacement and potential injury to a blood vessel, the bowel, or maybe the urinary tract. That demands immediate and decisive corrective action. Usually that means removing the needle, potentially reattempting entry in a different site, or even converting to an open approach to directly assess any potential injury. This is a critical double check.
Right, checking you haven't done anything vital. And the third?
And third, Pressure monitoring, once the CO2 insufflation actually begins. Once the insufflator tubing is connected to the Veress needle, the initial pressure reading on the machine provides immediate quantitative feedback. A low initial insufflation pressure, typically below, say, 10 or 15 mmHg, generally confirms that the needle tick is in a free, unrestricted space within the abdomen. The gas flows easily without high resistance. Conversely, a high initial pressure reading, maybe above 20 mmHg and rising rapidly, is a critical alarm bell. It strongly indicates that the needle tip is either obstructed, maybe by fat or omentum, it's still within dense tissue, like muscle, or potentially inside an organ or even a blood vessel. The gas is meeting significant resistance, signaling misplacement. This can be particularly dangerous, as continued insufflation into a vessel could lead to a gas embolism or into an organ, causing barotrauma or rupture. So what does this all mean for the surgeon and the patient? Each of these tests, the drop, the aspiration, the pressure, acts as a crucial sequential layer of verification. Because the initial insertion is blind, these tests provide the surgeon with real-time objective data points to build confidence in safe placement before proceeding with the next, more definitive step of inserting the larger primary trocar. Failure to properly perform and interpret these tests can have severe, life-threatening, and often irreversible consequences for the patient. As my residency mentor always drilled into us, never trust your gut alone on Veress placement. Trust your tests. It's a lesson that definitely sticks with you.
That's incredibly thorough for what seems, on the surface like a simple needle. The layers of safety are truly impressive. Moving on then to the actual working portals, Trocars and Cannulas. Can you clarify those definitions once more for us, maybe in a way that truly brings out their sophisticated function now that we've got the Veress needle context?
Certainly. Building on our earlier discussion, the trocar is the component that makes the initial opening. Think of it as the specialized drilling head, if you will. It's the sharp or blunt or optically guided obturator designed to safely penetrate the abdominal wall layers. It does the initial work. Once that pathway is established, the trocar is removed, and what remains inserted in the patient is the cannula, the hollow tube that stays in place throughout the entire procedure. These are the actual stable portals through which every single laparoscopic instrument will be introduced, withdrawn, and exchanged multiple times during the surgery. The cannula isn't just a passive tube, it's an active component. It maintains the integrity of the abdominal wall opening, it prevents gas leaks to keep that pneumoperitoneum stable, and it ensures smooth, atraumatic passage for expensive, delicate instruments.
And our sources highlight common sizes, 5 mm, 10 mm, 12 mm. Why these specific dimensions? Is it just about instrument fit, or are there deeper implications in choosing the size?
These sizes correspond directly to the standardized diameters of various laparoscopic instruments, and yeah, it's a crucial aspect of surgical ergonomics and strategy. It's not random. For example, 5 mm trocars and cannulas are very common. They're used for introducing smaller instruments like graspers, dissectors, scissors, or suction irrigation devices, the real workhorse tools. A big advantage is they create minimal port site defects in the fascia, which can translate to less post-operative pain for the patient and better cosmetic outcomes. Less scarring. The 10 mm and 12 mm sizes are typically required for the laparoscopic camera itself, which needs a larger diameter for the optics and light cable to provide clear visualization. These larger ports are also essential for introducing bulkier instruments like endostaplers for cutting and sealing tissue, specimen retrieval bags for removing resected tissue like a gallbladder or appendix, or larger surgical clips. These just have broader shafts. The choice of size isn't just about what fits, it's about balancing the needs of the specific surgical procedure with the desire to minimize patient trauma and maximize instrument functionality and ease of use for the surgeon. At medical conferences, surgeons often debate the optimal number and placement of these different size ports for different procedures, like, do you need 3 5s and 1 12 or 2 10s and 2 5s? It's always about finding that sweet spot.
Right, optimizing the setup. Beyond size, our sources detail key features for safety and function. Valves, sleeves, and fixation mechanisms. These sound like highly engineered components, not just simple tubes.
They absolutely are. Each feature is critical for both patient safety and maintaining a stable surgical environment. Let's break them down a bit. Valves are essential to maintain pneumoperitoneum. These aren't just simple rubber stoppers, they're often multi-component precision-engineered designs. You might see duckbill valves or flapper valves. They're carefully calibrated to allow smooth instrument passage while maintaining a really tight seal against gas loss, sometimes even under varying internal pressures or with different instrument sizes. Imagine trying to operate if every time you pulled an instrument out, your working space just collapsed. These valves ensure a consistent, clear field of view. Some modern ones even self-seal around irregular instrument shapes or when no instrument is present.
Okay, so the valves keep the gas in. What about sleeves?
Then you have sleeves. The design of the cannula sleeve itself, the part that sits in the abdominal wall, can vary significantly. Some are smooth, designed for minimal friction during insertion and removal. Others might have textured or helical, screw-like designs on the outside. These can aid in anchoring the cannula within the abdominal wall layers, providing better stability, or they might help distribute tissue pressure more evenly. The choice of bladed versus bladeless obturators, which we'll get to, also impacts the type of sleeve and the amount of tissue trauma during insertion. Some sleeves even incorporate specific materials or coatings to reduce tissue drag or, importantly for the camera port, to prevent fogging of the camera lens as it passes through.
And fixation, that sounds important for keeping things stable.
And finally, yes, fixation mechanisms are crucial for securing the cannula firmly to the abdominal wall. These prevent accidental dislodgement during surgery. If a cannula slips out, you lose your pneumoperitoneum instantly, potentially contaminate the field, or even cause injury if it's inadvertently pushed back in too far while instruments are still actively working deep inside. These mechanisms can range from simple external features like wings or ridges that provide some friction, to more robust threaded designs that actually screw into the fascial layer for better grip, or even more advanced systems like inflatable cuffs or balloons on the inside that provide internal anchorage once the cannula is placed. The goal is always rock-solid stability so the surgeon can focus on the operation, not worrying about the ports moving.
It's clear that every single detail is considered. That leads us nicely into the different types of trocars evolving toward safety. We heard about bladed, bladeless, and optical trocars earlier. What's the story of their evolution? Why the change?
This really highlights the incredible advancements in instrument design, constantly driven by that paramount focus on patient safety and minimizing tissue trauma. It's a great example of iterative improvement in surgery. Bladed trocars were the traditional workhorses for many years. They possessed a sharp, often pyramidal or sometimes conical, cutting tip. They're designed to literally cut their way through the tissue layer's fascia, muscle. While effective for penetration, this cutting action inevitably created a larger, sharper defect in the fascia, the strong connective tissue layer. This carried a higher inherent risk of injury to underlying structures like blood vessels or nerves during insertion. It also potentially led to larger port site defects that needed careful closure and could be associated with more postoperative pain or complications like herniation later on. As our understanding of tissue mechanics and wound healing improved, the drive was definitely to find a less traumatic approach.
Okay, so cutting wasn't ideal, which led to...
This led directly to the development and widespread adoption of bladeless trocars. These are designed very differently. They typically have cone-shaped or rounded tips, often made of a strong, sometimes translucent plastic material. Instead of cutting, they work primarily by dilating or spreading the tissue fibers apart rather than severing them. Imagine pushing your finger through a loosely woven fabric. The fibers separate and move aside rather than ripping. This stretching or dilating action is generally considered safer. It reduces the risk of injury to vessels and nerves, which can often deflect or move out of the way rather than being directly cut. Crucially, it also minimizes the size of the fascial defect left behind, potentially promoting faster healing, causing less muscle damage, and significantly reducing the potential for long-term complications like port site herniation, where abdominal contents protrude through a weakened incision site. The evidence supporting their reduced trauma and lower hernia rates is quite compelling, and it's a frequent topic of presentation and discussion at surgical symposia.
Less trauma, fewer complications. Makes sense. And then the optical ones add another layer.
And then, as we discussed briefly, optical trocars take safety arguably a quantum leap further, especially for that initial primary port placement. These incorporate a built-in scope or camera, allowing for direct visualization during entry. As the surgeon advances the trocar, they can literally see each tissue layer, fat, fascia, muscle, peritoneum, being traversed in real time on the monitor. This completely bypasses the blind aspect of traditional closed entry techniques like the Veress needle or even standard bladeless trocars. It's a tremendous enhancement to safety because it allows the surgeon to actively identify and avoid potential hazards like adhesions sticking to the abdominal wall, small blood vessels in the path, or even loops of bowel lying just underneath. While they might require a slightly larger initial skin incision to accommodate the camera lens or specialized training to interpret the visual feedback effectively, the confidence they provide, especially in patients with complex abdominal histories or previous surgeries, is invaluable. They truly represent a blend of the potential speed of a closed technique with the enhanced visual safety closer to an open one.
It's fascinating how a seemingly simple design change, like adding a tiny camera or changing the tip shape, can make such a profound difference in patient outcomes and surgeon confidence. Now, let's circle back to the Hasson cannula, which we mentioned earlier in the context of the open technique. It really sounds like a specialized, deliberate solution for specific problems.
It is indeed, and it plays a vital role in our surgical arsenal. It's not used for every case, but it's crucial when needed. The Hasson cannula, specifically designed for the open access technique, has a unique design tailored for maximum safety in potentially challenging scenarios. It features a distinctly blunt tip trocar. Unlike the sharp-bladed or even the cone-shaped bladeless trocars, it has essentially no penetrating sharp point at all. Its cannula also typically has a cone-shaped sleeve near the top and often little wings or eyelets that allow it to be securely sutured directly to the abdominal wall fascia.
Okay, so the blunt tip and the suturable sleeve, what are the specific advantages there, and how do they contribute to its specialized role? Why those features?
The primary advantage of the blunt tip is, first and foremost, the near elimination of puncture risk during the insertion of the cannula itself. Since the surgeon has already meticulously opened the abdominal wall layers under direct vision down to the peritoneum, a sharp trocar simply isn't needed or desired at that point. The blunt tip is just guided gently into the already created opening, maybe pushing aside any remaining loose tissue. It's a very deliberate, controlled entry into the established space. The suturable sleeve is also incredibly important. Once the cannula is in place, that cone-shaped sleeve sits snugly in the fascial opening, and the surgeon uses sutures to stitch it directly to the fascia. This provides extremely secure, leak-proof access. This is critical for maintaining a stable pneumoperitoneum throughout potentially long, complex cases, and it absolutely prevents accidental dislodgement. This sutured fixation offers unparalleled stability compared to other trocar types that rely mainly on friction or maybe in internal anchoring balloons. This combined design blunt tip, secure suturing directly contributes to its key advantage. It significantly reduces the risk of vascular and bowel injury, particularly during that initial establishment of access. Because of the direct visualization as you make the initial incision and then the completely blunt entry with the Hasson trocar into that opening, the chance of inadvertently damaging underlying structures is greatly diminished. It's really considered the gold standard for safety in specific higher-risk patient profiles.
And for which patient profiles is this technique and this specific cannula particularly ideal? Where does it truly shine, would you say?
The Hasson technique and cannula are most commonly indicated and really shine in patients who have had previous abdominal surgery, especially multiple previous surgeries, where intra-abdominal adhesions are highly expected or known to be present. Adhesions, as we mentioned, are those bands of scar tissue that can form after operations. They can bind organs together, or worse for initial access, bind organs like the bowel directly to the inner surface of the abdominal wall. In such cases, attempting a blind entry with a Veress needle or any sharp bladeless trocar carries an extremely high risk of bowel or vascular injury because the bowel might literally be stuck right where you're trying to insert your instrument. You just can't know for sure from the outside. The open technique allows the surgeon to carefully identify and safely dissect through these adhesions under direct vision before entering the main peritoneal cavity, protecting those vital structures. It's also often chosen for patients with large umbilical hernias, or sometimes in very thin patients, or in situations where there's a need to immediately remove a large specimen or perhaps perform a mini laparotomy for exploration through the same initial incision. It's a vital tool for maximizing safety in these challenging and complex cases. It really demonstrates that sometimes a slightly more involved, maybe slightly slower, initial step yields significantly greater overall safety. This tailored approach, choosing the right technique for the right patient, is a cornerstone of modern surgical planning and something emphasized heavily in training and practice guidelines.
So it really is about tailoring the approach to the patient's individual history and specific anatomical challenges. That really feels like a strong, unifying theme here. Personalized medicine right there within surgery. Our sources also reinforce cutting-edge innovation with optical and radially expanding trocars, circling back to them as a crucial part of this modern arsenal, representing that continuous improvement drive.
Yes, and it's worth revisiting these because they represent distinct, powerful advancements aimed at improving patient safety and potentially recovery. As we've emphasized, optical trocars allow that direct visualization during entry. This essentially eliminates the blind aspect, giving the surgeon real-time, often high-definition, visual feedback. Imagine being able to see, millimeter by millimeter, the tissue layers parting as you enter. This is invaluable for preventing inadvertent punctures of vessels or organs. It's a significant step forward in making initial access safer, particularly in situations where anatomy might be distorted or adhesions are suspected, even if maybe not severe enough to warrant a full open Hasson technique straight away. It's a technology that has gained pretty rapid adoption in many centers and is frequently discussed at meetings in terms of its impact on surgical training, reducing complication rates, and maybe even medical legal aspects. Then there are radially expanding trocars. These are truly innovative from a biomechanical perspective, how they interact with tissue. Instead of cutting or even just dilating tissue primarily in a linear forward fashion, they use a system that gently stretches the tissue radially, sort of outwards in all directions, like parting a curtain smoothly. This approach aims to minimize port site complications in a very elegant way. What are these complications we worry about? Well, postoperative pain is a big one, bleeding or hematoma formation at the incision site, and perhaps most significantly, postoperative herniation, where abdominal contents later push through a weakened fascial defect. Infection is also a risk at any incision. By stretching rather than cutting or aggressively dilating the tissue, these trocars theoretically cause less trauma to the muscle and fascial layers. This, in turn, may promote faster healing, reduce postoperative pain signals, and importantly, lower the incidence of those troublesome port site hernias. The discussions you hear at major surgical meetings often include comparing long-term data looking years out on hernia rates and chronic pain associated with different trocar types. These innovations highlight a real focus on minimizing the impact of the entry itself on the patient's overall journey to healing and long-term well-being.
It's just clear that the entire journey, from that very first decision to make an incision all the way through a complex surgical procedure, is paved with incredible thought, meticulous engineering, and a constant drive for improvement. And it's all aimed at one overarching goal: prioritizing patient safety. That really is the unifying principle binding all this together, isn't it?
Absolutely. It is the bedrock. It has to be. When using any of these access instruments or choosing any technique, safety is paramount, period. This entire discussion, all the details about design and technique, it really culminates in understanding how to use them safely. It's about applying all this knowledge from anatomy to instrument mechanics to patient factors to protect the patient at every single step. Every decision, every movement, every confirmation test revolves around this central principle. It dictates everything.
And that starts with the very first decision: choosing the right entry point. Our sources emphasize always choose the right entry point, usually infraumbilical. Why is that the default starting place so often?
Right. The infraumbilical site, meaning just below the belly button, is often the preferred choice for initial access, especially in a patient without prior abdominal surgery, what we sometimes call a virgin abdomen. Anatomically, it's typically where the abdominal wall is thinnest. This is due to the natural fusion of fascial layers at the midline, the linea alba, making it generally easier to penetrate controllably. Crucially, in this specific location, the major retroperitoneal vessels, the big ones like the aorta and vena cava, are generally at their maximum distance from the anterior abdominal wall, offering a relative zone of safety deep inside. It's also usually relatively free of major superficial blood vessels that could cause troublesome bleeding. However, it's vital to remember that usually is the key word there. It's absolutely not a universal rule. The surgeon always assesses the individual patient's anatomy, their body habitus, are they very thin, obese, and critically, their surgical history. They're looking carefully for scars, visible hernias, or any other anatomical variations that might make the umbilical site less safe or unsuitable. A thorough preoperative assessment and a careful physical examination right before starting are critical steps.
So definitely no one-size-fits-all approach. It's tailored. And we've talked about it multiple times, but given its absolute importance, it really bears repeating. Confirming intraperitoneal placement of the Veress needle. This is just non-negotiable, right? There are no shortcuts.
It is absolutely, unequivocally non-negotiable. Reconfirming the necessity of those confirmation tests, the saline drop, the aspiration, the initial pressure monitoring is critical. Cannot emphasize it enough. To reiterate, failure to confirm correct placement of the Veress needle before insufflating significant amounts of gas can lead to truly catastrophic complications. These include insufflation of gas directly into an organ like the bowel or liver, causing injury, insufflation into a major blood vessel, potentially causing a fatal gas embolism, or even insufflation just into the subcutaneous tissue or preperitoneal space. While insufflating into the tissue layers isn't usually life-threatening, it can lead to massive subcutaneous emphysema gas tracking under the skin, which can obscure anatomical landmarks, make subsequent trocar placement incredibly difficult or impossible, and cause significant patient discomfort and alarming swelling postoperatively. So this really raises that important question again. What happens if you don't confirm meticulously? The answer is severe, immediate patient risk, often with little chance of detecting the injury until it's too late. Meticulous adherence to these checks is a fundamental standard of care and a core element of surgical training and ongoing competency assessments. No shortcuts.
And once you're successfully in and the gas is flowing, it's about maintaining intra-abdominal pressure within that very specific range, usually between 12-15 millimilli HD. Why is that narrow range so incredibly important, and what are the risks of deviating too far either way?
This is a delicate and critical balance, and it's constantly being monitored and adjusted by those sophisticated insufflator machines, usually in communication with the anesthesia team. The pressure range of 12-15 millimilli HD is generally considered the optimal balance point. It creates and maintains a safe and effective working space for the surgeon while minimizing adverse physiological effects on the patient. If the pressure is too low, say below 10 or 12, you face several problems. You get insufficient working space, meaning organs aren't adequately pushed away from the abdominal wall. This leads to poor visualization and a significantly increased risk of accidental injury during instrument manipulation. It also causes the abdominal wall to become lax and floppy, making it harder to maneuver instruments precisely. It can even lead to what surgeons sometimes call a snowstorm effect if there's minor bleeding. The blood droplets obscure the camera lens because there isn't enough space, making fine dissection impossible. Conversely, if the pressure is too high, say consistently above 15 or creeping towards 20 millimilli Hg, it can have serious systemic consequences for the patient. It compromises their hemodynamics, their cardiovascular function. It can reduce venous return to the heart, increase systemic vascular resistance, making the heart pump against higher pressure, and significantly affect blood pressure and cardiac output. This elevates the risk of cardiac arrhythmias or even ischemia in susceptible patients. It also significantly increases the risk of gas embolism, where CO2 is forced into small injured vessels, and it can cause significant respiratory compromise by putting excessive pressure on the diaphragm, pushing it upwards and reducing lung capacity, making ventilation much harder for the anesthesiologist to manage. Furthermore, prolonged high pressure can cause gas to dissect into tissue planes outside the peritoneum, leading to extensive subcutaneous emphysema, which can track all the way up to the chest, neck, and face, causing alarming swelling for the patient when they wake up. So maintaining that precise 12-15 range is truly vital for both surgical efficacy and profound patient physiological stability throughout the procedure.
It really sounds like a constant dynamic monitoring act, a true collaboration between the surgical and anesthesia teams minute by minute. Finally, it's clear that not all patients are the same. Surgical decisions have to be deeply personalized. We need to talk about tailoring techniques for specific patients. First, obese patients. What are the particular challenges there for getting access?
Right. Obese patients present unique challenges for initial access, primarily due to their significantly thicker abdominal wall. This thickness comes mainly from an increased layer of subcutaneous fat, the panniculus. Consequently, to safely reach the peritoneal cavity, surgeons must often use longer Veress needles and longer Trocars. Standard lengths just won't reach. Attempting to use standard-length instruments in an obese patient risks insufficient penetration. This can lead to insufflation into the subcutaneous tissue, which creates this massive, diffuse gas pocket in the fat layer that distorts anatomy and makes subsequent proper entry almost impossible. Or you might just be unable to properly place the trocars deep enough to function, creating a dangerous and ineffective scenario. Identifying anatomical landmarks, like the umbilicus or the fascial layers, can also be more difficult due to the thicker abdominal pannus obscuring things. Some surgeons might employ specialized techniques like using a large clamp to lift the abdominal wall more aggressively, or even using handheld ultrasound guidance right at the bedside to visualize the needle tip's path through the layers in very challenging cases. These sorts of adjuncts are routinely explored and discussed, especially in bariatric surgery conferences where this is a common issue.
Makes sense, longer instruments for a longer path. And what about patients with prior surgery? This seems to be where the Hasson technique, the open approach, really comes into its own, as you said.
Absolutely. For these patients, as we extensively discussed with the Hasson technique, there's a significantly higher likelihood, sometimes almost a certainty, of intra-abdominal adhesions resulting from their previous operations. These adhesions, that scar tissue, can bind organs together or, crucially for access, bind organs like the bowel or omentum directly to the inner surface of the anterior abdominal wall, often right under previous scar sites or the umbilicus. This creates a highly unpredictable and potentially dangerous environment for any kind of blind entry. The bowel might be literally fused to the exact spot where you intend to insert your Veress needle or trocar. You just can't know for sure from the outside. Therefore, in these cases, surgeons almost always consider using or strongly prefer an open technique like the Hasson, or perhaps an optical entry device if the risk seems lower but still present. The open Hasson technique allows for direct visualization and careful dissection of any adhesions encountered right at the entry site, literally letting the surgeon see and safely navigate around potential hazards before breaching the main peritoneal cavity. Optical entry also provides that direct visualization as the instrument enters, helping the surgeon to identify and hopefully avoid injuring adhered bowel or vessels in real time. If we connect this back to the bigger picture, this is truly about personalized medicine within surgery. It's about adapting the approach, the tools, the technique to the unique anatomical challenges presented by each patient's individual medical and surgical history. It's a testament to the fact that while technology progresses rapidly, sound surgical judgment based on careful individual patient assessment remains absolutely paramount. These decision-making algorithms, when to use open, when to use optical, when closed, might still be okay. They're critical elements taught in residency and refined through experience, often presented as flowcharts or guidelines at, you guessed it, comprehensive medical conferences.
Wow. What an incredible deep dive into just the first foundational step of laparoscopic surgery. It really is so much more complex than one might think. We've journeyed from the meticulous decision to enter, through the ingenious instruments themselves, to the life-saving protocols and checks. So, to summarize, the key access instruments in laparoscopy that we've covered include the Veress needle, with its brilliant spring-loaded safety mechanism.
The classic starting point for many.
Then a whole variety of sophisticated Trocars and Cannulas, each designed for various roles and offering different levels of safety, bladeless.
Evolving constantly towards less trauma.
The specialized Hasson cannula, really crucial for open access in those challenging cases with prior surgery.
A safety net for adhesions, essentially.
And finally, those cutting-edge optical entry devices that are really redefining visualization during that critical first entry.
Exactly. Each of these tools and the specific techniques that accompany them has its place. They each have distinct advantages and, yes, important limitations or situations where they might not be the best choice. Together, they form a critical and constantly evolving toolkit for surgeons. A toolkit designed to let them safely initiate pretty much any minimally invasive procedure they need to perform. It's a complex interplay of engineering brilliance, detailed anatomical knowledge, meticulous surgical technique, and importantly, continuous learning and adaptation based on new evidence.
And the ultimate takeaway for us, the listeners, seems profound. Mastery of these instruments and an unwavering commitment to these safety protocols ensure not just a safe beginning, but really a stable foundation for the entire laparoscopic procedure that follows. This mastery, this attention to detail right at the start, directly translates to better patient outcomes, fewer complications, and the continued success and expansion of minimally invasive surgery, pushing the boundaries of what's possible in the operating room.
Precisely. Knowledge is most valuable when it's understood and applied correctly. And here, applying this nuanced understanding of surgical access, choosing the right tool, using it correctly, performing the checks, it's literally about saving lives, minimizing complications, reducing pain, and ensuring the best possible recovery for patients undergoing surgery. It's really a testament to how far surgical techniques have come, built on this foundation of constant innovation, always coupled with an ethical imperative for safety above all else.
It truly is an incredible journey. And it makes you wonder, as we continue to push the boundaries of minimally invasive surgery even further, maybe towards single-port surgery or robotic procedures, and with our deepening understanding of these foundational tools and the critical moments of entry, what further innovations might emerge? Could we see maybe AI-driven guidance systems integrated into Trocars that transform even the most challenging blind access into an entirely visualized, risk-mitigated entry? Or perhaps augmented reality overlays projected onto the surgeon's view, showing real-time anatomical data from pre-op scans, making that very first incision as safe and predictable as the last stitch. Something to mull over as you consider the incredible journey of modern medicine. Thanks for joining us on the Deep Dive.